Hello and welcome to Georgia Institute of EMS's online presentation of fluid resuscitation. This section is meant to meet the standard for the Advanced EMT NCCP National Component for your bi-yearly refresher training. So with that, let's go ahead and let's get started and dive into this topic. Today, like I said, we're going to be going over fluid resuscitation, and you can go ahead and allot about 30 minutes to this section. So we should get about a half hour of Con Ed out of this, and hopefully it'll be very beneficial to you. So let's start off, and I'm going to go ahead and introduce myself. My name is Tom Camplain. I am here at Georgia Institute of EMS, and I am the CEO here, and I'll be your instructor guiding you through this section. If you need to get in touch with me, you can get in touch with me at tom@gaiems.com. You can also call us at 678-561-2368. You can reach us on the web at georgiaemt.com. And don't be afraid to reach out there with any questions, comments, concerns, or anything that you may have, especially regarding this topic or anything we can help you with. So, let's dive right into this. The main things that we want to go over in this section are going to be, we want to talk about fluid resuscitation, and to get to that point, to get you up to speed as an advanced EMT, we want to talk about the concepts of permissive hypotension, what it is, what you're expected to do, and what's the benefit to your patient. We're also going to discuss some of the research regarding fluid resuscitation in the field and how they kind of came about this permissive hypotension standard. And we'll talk a little bit about the old standard and how they came up with that old standard and comparing it to the new standard as well, just to give you a little context into it there. So with that, let's go ahead and let's dive right into it and knock this out. So fluid therapy. Usually out in the field, an advanced EMT that's working on an ambulance, you're going to run into two main fluids out there. More than likely, it's going to be the normal saline and lactated ringers. Now, some places may have some other fluids out there. You may have like D5W, or you may have D5 quarter normal saline is what we'll call it, or half normal saline, or D5 quarter, or D5 ringers. And so it just depends on the system you're working in and whatever. But for the majority of people out there, it's probably only normal saline and lactated ringers. And I know there's a segment out there that is only normal saline. Now, we can find these fluids in different packages, per se. You'll have them in, most of the time, you're going to have a liter bag of saline or ringers, or you may have a half-liter bag of saline or ringers. You may even have 250 cc's, 100 cc's, down to 50 and 25 cc bags. So depending on what your patient needs will depend on what size bag you may grab. So what we're going to do here is we're going to talk a little bit about our goals of fluid therapy, what it is we're wanting to accomplish by giving the patient fluids. And then we're going to jump into a little bit about permissive hypotension and get you up to speed on that. So goals of our fluid therapy. The main goal that we have with fluid therapy is to maintain perfusion to the vital organs. And I'm talking about like the heart and the lungs, and the brain and the kidneys and so on here. We are in like a initial traumatic situation, and us trying to worry about everything isn't going to work. Our main goal is to try to halt the progression of shock and to maintain perfusion to these vital organs. So how are we going to do that? What are we going to use as our scale or our guide or our roadmap to get us to where we need to be with this patient? And it's going to be right in front of us. It's going to be our patient themselves. We're going to utilize that assessment. We're going to assess this patient, get a baseline, and figure out where they are. What was the mechanism of injury? How much fluid have they potentially lost here. Is it internal bleeding? Is it external bleeding? Do I need to stop that external bleeding? And I just want to throw out there, just remember that every red blood cell that you see that's laying on the ground is one less red blood cell that patient has to circulate oxygen and nutrients and everything else around. So we want to stop the bleeding as soon as possible, and we don't want to further or cause more bleeding or make it worse. And that's something we're going to talk about here in a little bit. But our main guide that we're going to use to help us understand where our patient is, how much fluid we need to give, have we given enough fluid, is it too little fluid, is going to be the level of consciousness and the mental status. Use that as your guide. If your patient is unconscious, unresponsive, and they have like tanked out blood pressure or nothing, well then more likely they need fluids. But if they have a good mental status, they're talking to us, and let's say their blood pressure is like 88/40, maybe they don't need a whole lot of fluids. We just need to keep them steady, try to keep them in that area. And we're going to talk about that in the permissive hypotension there. But regardless of whatever model we're using or protocol, we should be there just to maintain that mental status. Maintain adequate perfusion of the brain, maintain adequate perfusion of the heart and lungs. Because bringing that blood pressure to a normal or high level, let's say you've got a trauma patient and you got there and their blood pressure was 86/40. Raising that blood pressure to 140/80 is going to be detrimental to the patient and can be very harmful to them. And that's something that we really don't want to do. And we want to avoid at all cost. Remember, we're there to do no further harm to the patient. And if we are just doing something just for the sake of doing it because, hey, I brought them into the ER and they had a normal blood pressure, and then all of a sudden they die because they have no clotting factors and they have nothing to transport oxygen to, an hour later, well, that could have been part of our fault as well there. So we don't want to do any further harm. So let's talk a little bit about permissive hypotension. Like I said earlier, our goal is to establish and maintain a blood pressure that promotes perfusion of the vital organs. It's not about us getting a good number. It's not about us getting that 120/80. These patients may be just fine at 86/40. Okay. Like I said earlier, we're doing our initial assessment. Whenever we get there, it's the scene size up, it's the scene safe, number of patient, mechanism of injury, and so on. Get the patient looked at so that we can get that general impression. If we see there and they've been shot in the neck and they're squirting blood everywhere, we got to control that bleeding. So one of our first things that we want to really focus in on is stopping any further loss. Stopping further fluid losses has got to be a priority. And we can do that by utilizing direct pressure. If we need to, we're going to put a tourniquet on that patient as soon as possible so that we stop that any further blood loss. The blood that they have circulating is the best fluid for them. Okay, I know that we carry fluids and it's cool and we can do things, but the best fluid for that patient is their own fluid, and we want to try to maintain that as best as possible. Okay, so let's identify and control that bleeding as soon as possible. Now, sometimes it may be difficult to do because it could be internal bleeding, but there's some things that we can do for internal bleeding. We can splint like a pelvis or splint in a femur fracture, and so on. So next, let's get, this is kind of obvious, but we need to gain IV or IO access. Which one's better? Well, IV access is hopefully readily available. If we can get in a good large bore IV, we want to, but if we can't get in a large bore IV or just an IV at all, then we may need to go to the interosseous route as well. We can give fluids through the interosseous route, but the IV route is a little less invasive. So don't just be like, oh, I'm going to try to put this 14 gauge in when you could have easily got a 16 gauge in or an 18 gauge in just because you say, oh, I can fall back on the IO. Well, that's just more procedures for the patient that could have risk. I mean, the IO is not without risk either, even though it's starting to become more mainstream. So if you can get the IV, let's get IV access as soon as possible. So then we need to determine, hey, what fluids is it that we want to give? Do we want normal saline? Do we want lactated ringers? And that question is going to be answered in your protocol. Whatever it is your medical director has established for you. A lot of services are doing normal saline and lactated ringers. Some services may only be doing normal saline. If there's anything different I'd like to know out there, that would be great so that I could further the conversation on. If anybody has any other things, send me an email, let me know, and I'll go in and I'll redo this presentation for it. But I think for the most part, your main fluids is going to be normal saline, lactated ringers. Start one in one arm, one in the other arm if needed, and so on. Or you may be doing 2 normal salines. So once we get that going, what is our target? How much fluid do we give? What are our parameters there? And some places are saying, hey, let's do like 250 to 500 cc fluid boluses at a time. And let's try to keep that blood pressure somewhere between 80 and 90. Somewhere around there. So we're going to titrate it back and forth, which means that we're going to have to frequently assess this patient. So this isn't something that we're going to be able to just assess them once every 5 or 10 minutes. We're probably going to be getting multiple blood pressures, maybe every 3 to 5 minutes. If you've got an automatic BP machine, it's probably, run it every 2 to 3 minutes. But if you are using that automatic BP machine, please, oh please make sure that it's accurate. There's nothing worse than rolling up in the hospital thinking, oh, I've got this beautiful blood pressure of like 92 over 40, and we're doing great. And then you get there and their blood pressure is really 70 over something because your automatic BP was telling you something wrong. Check it manually. All right. Every few times, maybe you need to check a manual one to make sure that you are on target with it as well. And you may need to, palpate it if you need to, or auscultate it, either one. So once we've kind of got those parameters in line and we are ensuring that we have good data by getting, a good blood pressure on this patient, we want to try to keep that somewhere between 80 and 90, and we can alternate those fluid boluses like around 250, 500 at a time. We don't want to overdo it, okay? Giving fluid too much fluid, especially too fast, has had detrimental effects on these patients. And our goal is to not cause any further harm. And we're going to talk about some of the things that doing that too much fluid and stuff can actually do to these patients that we don't want done. So what if they have a brain injury? Because, when you have a patient that could have a potential brain injury, their blood pressures are typically higher, right? You can have, that patient with that high blood pressure and that low pulse because they have some cerebral edema going on due to maybe a bleed or something that's in the cranial vault. So if we are suspecting that, we want to increase that to around 100 systolic. Once again, we don't want to increase it too much, but we have to have it high enough so that we can perfuse the brain. If you remember back in some past classes, or if you've had any classes in TBI, the traumatic brain injuries and stuff, one incidence of hypotension in a traumatic brain injury or a patient suffering a traumatic brain injury increases their incidence of mortality by a whole lot. And we want to prevent that. That's that secondary brain injury that we want to prevent. We want to keep that blood pressure somewhere around 100 if possible, if they have that suspected brain injury, okay? So that's our fluid therapy. So let's talk about some of the dangers that we have, because everything we do, there are risks and benefits. And whenever we're trying to determine what it is we need to do, we need to look at those risks versus the benefits. And if the benefits outweigh the risk, then generally we're going to kind of lean that way. That's why we are lucky now to have research and evidence-based medicine to back up what it is we do. And I'm going to talk about that just a little bit here while we're going over the dangers of fluid administration. And it's not just all about the dangers. I'm also going to talk about the benefits as well while we're going over this. So let's look at the excessive fluid administration. You know, the previous slides, we've talked about this permissive hypotension, which kind of implies that, hey, I'm not going to be giving them a lot of fluid. It's not that we're not going to give them any fluid. We just may be giving it at smaller increments and really paying attention to the blood pressure and using that blood pressure and their mental status as our driving sets of data that's going to let us know if we've reached the point that we need to reach with these patients in regards to how much fluid we give them. So what is it that is so bad about excessive fluid administration? Why is it so bad? Because way back when we were giving, we would start 2 large bore IVs. We'd have a leader in one arm and a leader in the other, both running wide open. And we'd be going down the road to the hospital, get them to the hospital, get them to the surgeons, right? Well, what we were doing is we were really diluting the blood that was in there. And when we were doing that, we are really canceling out and messing up all the clotting factors and platelets that this patient has. And if they have any internal bleeding going on, we are pretty much making it worse. We're preventing the patient's own body from being able to take care of itself. And if the patient's body has been taking care of itself in the form of forming clots to help stop that blood loss, if we come in and we have 2 large bore IVs and we're running them wide open, the possibility of us washing that clot away is pretty good. And once we wash that clot away, what happens? The bleeding starts back again. The patient starts losing blood again. And remember, the red blood cells do the patient no good unless they are inside the vascular system, unless they are in that circulatory system circulating nutrients and oxygen or waste products away. They're not doing any good in the abdomen or in the pelvic cavity. We need them in the circulatory system. So us pushing all that fluid pushes all the clots that could have formed. It could push them out and cause the bleeding to start back, which causes the patient to get worse. But on our end, we're looking at the blood pressure. Oh, the blood pressure's going up. Oh, we must be doing the right thing. But inside, we're not. The other thing that we were doing is that we were expanding the area of the defect. So let's say they have a open wound or they have a ruptured vein somewhere or artery. Let's say that artery is ripped open or cut, and the patient's blood pressure dropped, which meant that there was less pressure on that open wound inside that artery, which allowed the platelets to stick to the area, and the clotting factor started forming, and it formed a clot. Well, then we come in and we see the patient's blood pressure. Oh my goodness, the patient's blood pressure is 82/30. We need to get 2 large bore IVs started. We need to really push this normal saline and lactated ringers wide open. And next thing you know, we've dumped 2 liters of fluid in this patient in the time, let's say 10 minutes or less. And during that 10 minutes, what we did is the clots that had formed, we now have washed them away, and now the patient's bleeding more. But also what we've done, potentially have done, through increasing the blood pressure and in making the artery expand, we just made the hole that was there even bigger. potentially, which makes it even harder for that patient's own platelets and own clotting factors to hop in there and stop that bleeding. And we're just pushing more blood out that little hole and making that hole even bigger, which isn't good. Also, through the loss of the red blood cells that we've lost through either the internal or the external bleeding because we've been pushing all these fluids, we've lost red blood cells. And red blood cells is what the patient needs to circulate and move oxygen and nutrients around and offload carbon dioxide back and forth. We need all those. So what we did essentially is reduce the capacity of the fluid in that vascular system to circulate oxygen and nutrients, because normal saline, lactated ringers, D5W, and so on does not circulate or transport anything. All it does is expand volume. It's just a volume expander, and that's it. So what about inadequate fluid administration? So we talked about, hey, what happens when we give too much? So now, oh my goodness, I'm afraid to give any fluid at all. Well, don't be afraid to give any fluid. We still got to give fluid, and we still got to treat these patients, okay? Because if we are not giving enough fluid, then we're going to have decreased perfusion of the vital organs that are so important. We need to be able to have enough pressure in the vascular system so that what blood and stuff in there can be transported to the brain, to the heart, and to the lungs, to the kidneys, and so on. So we're going to see this initially in the patient's mental status. So if we are not giving adequate amounts of fluids, we're going to see a potential altered mental status because of the decreased perfusion to the brain tissue. Also, one of our main goals out there whenever we are encountering these patients is to halt and slow down the progression of shock. It's vitally important for us to do that, because once the patient reaches the state of irreversible shock, there's no coming back from that. And our goal is to get there. Hey, stop the external bleeding. Get the pressure to an adequate level so that the organs can be perfused while we're transporting them to a surgeon, to a trauma facility that can adequately take care of these patients, which is extremely, extremely important for them. So I've talked about a little bit about the dangers of the fluid resuscitation there. And I've talked about inadequate fluid administration, excessive fluid administration, and we've kind of talked about, which all kind of compiles around about, looking at the dangers of what it is we're doing. Giving fluid is not a benign thing. It comes with its dangers. It comes with its benefits. So what are some of the benefits to this? Well, beneficial is that we are halting the progression of shock. We are helping perfuse those vital organs so that we can get a viable patient, hopefully, to that trauma facility so that they can be adequately treated. So now I want to talk about this a little bit. I don't have a good slide up for it, but we'll just sit here and talk about it and discuss it a little bit. Where did we get this information? Because one of the things I'm supposed to talk about in this section is the research behind it. Because so often in EMS, we've used anecdotal information. And anecdotal is kind of like, well, it makes sense that it should work, but it really doesn't work. So we really need evidence. We need something that gives us some proof in regards to what it is that we are doing. So what did they do? Well, way back in the 60s and 70s, they did a lot of studies on animals in fluid resuscitation. And back then, they were getting results like, hey, they were taking pigs and bleeding them out, and then they were resuscitating them with crystalloids. And the results were pretty good. For the most part, they were saving, the pigs' lives. Well, we started applying that to people out in the field. And we saw that, hey, it worked some, it worked some and sometimes it didn't. But what were really the numbers? And when you started really examining the numbers, it was a mixed bag. So then they start really looking at this research that was done, and they found a lot of flaws in the design of it. So then they started recreating it under some updated parameters and some updated design, and started finding like, hey, are we actually doing more harm than good? So then they started looking at the permissive hypotension and started comparing. I started looking at some incidences of patients that received zero fluid in the pre-hospital setting versus those that did, and started seeing, hey, these that didn't receive any fluid, hey, they're surviving too. Why? Why is it that they're surviving? So they started doing more research and looking into it and finding out that, hey, some of the things that we're doing, we're giving way too much fluid. We're giving too much fluid, and we're giving it too fast. And when we're doing that, we're putting the patient in a situation where the natural effects and the natural protective mechanisms that we have are being overridden. We are washing clots out. We are making injury worse by doing this. So let's look at limiting, because not giving the patient fluids in a lot of situations isn't a viable alternative either. We need to get them to that standard of where they're at. So they started really examining and starting clinical trials, and before that they did animal trials, and the animal trials were successful as well, finding out like, hey, we really don't need a ton of fluids to sustain life. Does this sound familiar? Like, we don't need a lot of oxygen either. Remember, like in CPR, remember it used to be airway, airway, airway. Oh my goodness, you got to get that airway. And then once you get that airway, we got to get an IV. But now the research is showing that, hey, maybe we don't. Maybe we can get by with the blood pressure in somewhere in between the 80s and 90s. Maybe if they have a head injury, maybe closer to 100. But we're getting by with it. So they started putting this in the field, and that's where we're at with permissive hypotension. Okay, permissive hypotension is do not administer fluids in the field. That's not it at all. Permissive hypotension is let's do it in a methodical way where we are giving increments of volume expanders in an effort to just maintain a blood pressure. Now, one thing I want to go ahead and put out there as well, and I want to remind you, is that it takes about 3 liters of crystalloids to equal 1 liter of blood. So it's about a 3-to-1 ratio. The fluids are going to move from the vascular space to the interstitial spaces, and so on and so on. So this isn't something where, hey, I've got a blood pressure of 87 or 86 or 88 over 40, and I'm good. Don't throw your hands up and say, hey, I've got where I'm at, put it on KVO, and let's go to the hospital. We're good. Got a 20-minute transport time. I'm good, and we got a good blood pressure. I'll check in about 10 or 15 minutes. You can't do that, because even though you've got that blood pressure right now, that doesn't mean that it's not going to change. So you may want to make sure you are checking that blood pressure every 3 to 5 minutes and making adjustments as necessary with this patient. So that's the gist about the research there, and trust me, there are a lot of good articles out there if you want to go out there and Google permissive hypotension. Australia has done a lot of good research. The UK's done a lot of good research, and there is a whole lot of good research here in the United States and in Canada as well regarding it. So our conclusion, our goal here is to maintain a blood pressure that promotes perfusion of the vital organs. That is our main goal. And this can be accomplished by utilizing permissive hypotension, by gradually making sure that we are maintaining a blood pressure in the 80s to the 90s. Now, I want to go ahead and say this as well. If you've got that patient and their blood pressure is like 50 over nothing, well, those patients may need some a lot of fluid boluses. But once you get there in the 80s, then you start backing it down, okay? In these patients that you've got there, you want to try to keep them there, okay? One thing I just want to remind you is that fluid therapy, just like any other therapy, has its benefits and dangers. Giving too much fluid or not enough fluid can be detrimental to the patient. So we want to utilize those assessment techniques and make sure that we are maintaining blood pressure that provides adequate perfusion to the major organs. Well, that's it. That was a quick 30 minutes. I hope that this was beneficial to you. If you have any questions, you can contact me here. Once again, I'm Tom Camplain. You can contact me at tom@gaiems.com. Give us a call at 678-561-2368. And you can check us out on the web at georgiaemt.com. Please come and, let us know how it went. Give us your comments, feedback, and if you have any questions regarding this presentation, need some clarification on anything, please feel free to let me know, and I'll be more than happy to help you out in any way I can. Once again, I want to say thank you, and I hope y'all have a wonderful day.